Greetings, students. What we have here is a video about the peripheral nervous system, the nerves that I'm going to test you on, and specifically where to find them on the two models that I'm going to be using. I'm going to reiterate the sensory distribution that these nerves cover and the single select motor function that they're responsible for, that I will test you on. Please remember that pretty much everything I'm saying here is more complex, more detailed, more nuanced than what I'm explaining here and in class. The nervous system in general is really complicated. You already know this, but we have boiled it down and simplified it to give an overview, to focus in on the most common, major, clinically relevant structures, and that's how we're doing it. That's how I'm doing it. So, starting with the upper arm, and starting with the first nerve on our list, the axillary nerve. The axillary nerve is a component of the brachial plexus. It's named for its course through the axilla. It is not named for the skin of the armpit. In fact, as it passes laterally, as it comes off the brachial plexus, it dives deep between the rotator cuff muscles, down and deep in between the subscapularis and the humerus. It dives and it emerges posteriorly. It emerges posteriorly and it wraps around laterally. So just try to pay attention to how I'm moving this thing every which way, but this is lateral. The shoulder and the deltoid would be here, and this is medial back here. So you're looking at a lateral view. It emerges posterior to the humerus and wraps around. Here it innervates the deltoid muscle. Motor. Sensory, it brings information from the skin over the shoulders. Okay, that's the axillary nerve. The next nerve on our list is musculocutaneous. Musculocutaneous nerve, also a branch of the brachial plexus, just like all of these are. It is not easy to see on this model, the musculocutaneous nerve, and it's not easy to see on an arm, the musculocutaneous nerve, because it dives down, it pierces coracobrachialis through and through, like an arrow being shot through on its way to course distally beneath or deep to biceps brachii. And so it does so, and you can kind of see on that model how number 70 pierces coracobrachialis and through, and it travels between coracobrachialis and biceps. So imagine someone standing behind, well, enough said. Deep to biceps, motor innervation to biceps is musculocutaneous. And as it courses down in branches, it collects somatic sensory information from the lateral or radial side of the forearm. Okay, that's musculocutaneous. Next is radial. Radial nerve is great. Courses posteriorly. Okay, it's labeled on this model. If you take off brachioradialis, you'll see the label for this nerve is actually here in the antecubital region. It's number 80. But the nerve begins, of course, much more proximally, and it supplies motor innervation to the powerful extensor of the elbow, triceps brachii, as well as collecting sensory information from the posterior arm, a strip of the posterior forearm, and that characteristic distribution of the posterior dorsum of the hand laterally, the proximal portions of the dorsal skin of the digits, 1 through part of 4, and this sort of lateral swath of the skin of the thumb. Hard to see on here. Check out the diagram. Looking at that diagram, much better than my verbal description of it. But that's the motor and this sensory of radial. It's number 80 on the key, but the 80 is right here. But don't forget that this territory is quite extensive. Okay, extensive, and it innervates extensors. Not bad. Median nerve, I love the median nerve. Love the median nerve. It of course, is a product of the brachial plexus. It comes off down immediately. It courses with the brachial artery. It crosses medially to it, and it dives down deep, and it goes and it goes and it goes. Its final destination is to provide sense. Oh, and let's not forget. Let me just say while we're here before we get there. There is a band of connective tissue that forms a bridge between carpal bones. And the carpal bones form a valley, and this bridge of connective tissue bridges it, like if you built a bridge over the Grand Canyon, and it forms a tunnel. And through this tunnel pass many tendons that extend the digits and so forth, as well as a single nerve. It's the median nerve. The median nerve is susceptible to compression as it passes through the carpal tunnel. Compression from what? From inflammation and swelling that is a result of repetitive movements of those tendons. You know, just to oversimplify things. Those two structures, the carpal bones and the tough flexor retinaculum, form a really unforgiving tunnel. That pressure, if anything, is going to squeeze things inside the tunnel, not expand the tunnel itself. And so tendons do not care if they get compressed by external forces like pressure and fluid. They do not care, but the median nerve cares. The median nerve is susceptible to injury and compression as it passes through the carpal tunnel, and the symptoms, the classic symptoms of carpal tunnel syndrome, will be numbness and tingling of the sensory distribution of the median nerve, which is the palmar side of the hand, digits 1 through 3, and the lateral half of 4, as well as the fingertips of those digits, the dorsal fingertips of those digits. You can see that distribution on a diagram, probably better than I can describe it, but that is the important, unique, and characteristic sensory distribution of the median nerve. And on its way there, it sends off branches to innervate the famous and powerful flexor of the wrist on the radial side, FCR, flexor carpi radialis. Flexor carpi radialis receives motor innervation from the median nerve. Ulnar nerve, again, the ulnar nerve on this model is a little bit difficult to see because of its course, but it branches off and it comes down, it dives, and it passes posterior to the medial epicondyle humerus, where it again is very susceptible to injury. This doesn't show the nerve in that area, but there's very little tissue between the skin. There's very little tissue between the skin and the ulnar nerve. And on the other side of the ulnar nerve is, passes behind a very sturdy, hard bone. And so it's very susceptible to injury if it's compressed by an outside force between the bone and an outside force. It's gonna suffer, and it's gonna cause a probably brief and uncomfortable sensation along its sensory distribution, which is going to be the medial forearm, the palmar and dorsal aspects of the medial hand, that region known as the hypothenar region, and the medial half of the fourth digit. Okay. As well, the ulnar nerve innervates a number of muscles on the way down, but the one I picked out is flexor carpi ulnaris. Okay, flexor carpi ulnaris is innervated by the ulnar nerve. I was going to tell you what it's on here. It's labeled 74 or 75. It has a couple of different labels on it, but it's seen here. It's seen here coursing medially down the forearm, and it passes over and lays on top of the flexor retinaculum along with the ulnar arteries. It goes forth to form that superficial palmar arch, and it is not susceptible to compression by forces and pressure building up inside the carpal tunnel because it's not in the carpal tunnel. So true carpal tunnel syndrome will definitely not produce neurologic symptoms in the fifth digit, for instance. But if you whack the ulnar nerve up here, most you may feel a kind of a lightning bolt or pins and needles clear down to the pinky finger, which I think is kind of cool. And maybe the next time you whack your funny bone, you'll have sort of a new appreciation for that phenomenon. Okay, it's the upper extremity, for lab at least. Lower extremity, again, I've got 5 nerves on the list. The 3 major nerves of the lower extremity that I have branch pretty extensively, especially femoral and sciatic. And I just want to reiterate the idea that these nerves branch extensively. They give rise to new named nerves that perform functions in the lower extremity, and I have really simplified it. And the diagram that I showed you guys for the femoral nerve, not a big area of the femoral nerve, these are all branches of the same parent nerve. But just remember that I have simplified things. Oversimplified, that's, I guess, up for debate. Same goes for sciatic. Sciatic branches into a number of nerves, including the tibial nerve and the common fibular nerve. But as well, a lot of these branches have names, but I have simplified it so that I showed you all the territory that parent nerve covers, but I have not made any distinction between all the many branches of the sciatic nerve or the femoral nerve. Okay, so at the top is going to be obturator nerve. Obturator nerve passes, I'm going to put my finger on it, here from more or less lateral to medial and through the obturator canal, and it dives down bound for the medial compartment of the thigh. It innervates the medial adductor muscles, gracilis, adductor magnus, adductor longus, adductor brevis, those muscles that bring the leg from an abducted position back into anatomic position. It adducts the thigh. All these medial muscles do. And it as well collects sensory information from the skin of the medial thigh. That's the obturator nerve. On our handout, I say adductor muscles. That's fine to group those muscles in the medial compartment together and refer to them as adductor muscles for this purpose. That's fine. Anteriorly and superiorly, we see this nerve coming in from in between the iliopsoas, from the iliacus and the psoas major. It comes down and it dives underneath the inguinal ligament, and it courses along with the femoral artery and vein. This is the femoral nerve. The femoral nerve comes anteriorly, and it innervates the quadriceps muscle. It innervates the anterior muscles. It innervates sartorius and the quads, rectus femoris, and the vastus, lateralis, medialis, intermedius. These muscles that extend the knee. As well, it provides pretty extensive sensory territory, including the anterior thigh. Femoral. Finally, will be the sciatic nerve posteriorly. If you look posteriorly, we've removed gluteus maximus from this, and we see really quite a large golden nerve coursing posteriorly and deep to the hamstrings. If I take off the hamstrings, and look here, we're seeing the sciatic nerve come, and the branch point is proximal to the popliteal fossa, and it gives rise to the tibial and common fibular branches. Tibial branch, the tibial nerve, dives down into the popliteal fossa between the heads of gastrocnemius, back there in the popliteal fossa with the popliteal artery and vein. Up here it innervates the hamstrings, with the exception of the short head of biceps femoris. The tibial nerve innervates the hamstrings. It comes down and innervates the plantar flexors. Innervates a number of other things, tibialis posterior. But the main ones we're focusing on is hamstrings, except short head of biceps femoris and the plantar flexors. Common fibular nerve branches and courses laterally, innervates short head of biceps femoris. On the model, all I need you guys to know for the lower extremity is sciatic, obturator, femoral nerve. Okay. For your information, sciatic nerve is called 63, femoral nerve is called 59, depending on where you look at it, but it's called 59 proximal to the inguinal ligament, and obturator nerve is called 61 before it passes through the obturator foramen on the way to the medial thigh. So, it's a good bit of information. It requires you to go back and think once again about some of the muscles that we learned. But you have to admit it's an abbreviated list. But I want to think about and discuss some specific muscles because part of the reason I set the class up like this is to build, and as we go, bundle everything together and tie everything together. And so now, if you consider, for instance, the femoral region, Unit 1, we learned about the femoral region. Now we know there is a femur, that there are muscles attached to the pelvis and femur, and tibia that move the thigh and knee joint, the hip and knee joint. We know that there are arteries and veins that go to and fro beneath the inguinal ligament and supply the quadriceps muscles, all those interior muscles, the femur itself. They supply as well the nerves that pass through, the lymphatic vessels, the adipose tissue in that area, the connective tissue in that area. That's the femoral artery and vein. And now we know that there's a femoral nerve that goes through to supply motor innervation to anterior muscles of the thigh, as well as collect sensory information from the distribution that you can see on that diagram. So we can consider, as we learn these different systems, we can begin to consider regions. And you can consider the femoral region, the bones, muscles, vasculature, the nerves, all of the connective tissues like fat and the fascia and the skin. And so all of the systems we've learned about, you can consider in a region, and there is a way of thinking about anatomy known as regional anatomy, and you can approach it that way. I think easiest to approach it that way once you have a foundation of the systems, but it's a great way to think of it, and it's useful and critical to think of anatomy in that way when you're taking care of patients. All right, email with questions.